At the American Society of Hematology, 2 phase 3 trials, BRUIN CLL 313 and BRUIN CLL 314, place a non-covalent BTK inhibitor, Pirtobrutinib, firmly in the spotlight. One study compared Pirtobrutinib with chemoimmunotherapy in previously untreated CLL, while the other challenged ibrutinib head-to-head. Today, I'm joined by Professor Clemens-Martin Wendtner to discuss what these data really mean for clinical practice. Thank you, Mr. Wendtner, Professor Wendtner, for taking the time to talk with us today.
Yes, you're most welcome, Mr. Anderssen. Thank you.
Thanks a lot. So, Professor, let's start by putting the data into today's CLL treatment landscape. So the concrete question is, these 2 phase 3 trials both move Pirtobrutinib earlier in the CLL setting. And from your perspective, how significant is this moment for BTK inhibition in CLL?
Okay, so we have to say that the classic covalent BTK inhibitors, like, let's name them ibrutinib, acalabrutinib, zanubrutinib, has very firm place in the CLL armamentarium. So they are approved in frontline and in relapse setting. And now we have Pirtobrutinib. It's approved by the European Medical Agency from second line on, so relapse and further. The new thing here is this drug, Pirtobrutinib, the first non-covalent BTK inhibitor in market, is now being tested in frontline, and we have 2 positive trials. This has to be stated. So the side effects are very good. So it's a very manageable treatment. Patients experience few side effects, but I have to stress, Pirtobrutinib at this point is not approved in frontline, neither by FDA nor by EMA. And so to be also a little bit, critical, but in a constructive way, the German CLL study group, you're talking to me as the past secretary of this big cooperative group, we have also had a phase 3 trial at ASH, showing that time-limited therapy is the way to go. So there's a little bit contradiction, as you see. Pirtobrutinib is a continuous therapy, although very modern. And we say time-limited therapy is the way to move. So what is the future niche in answer to your question?
Exactly.
It could be elderly patients. They just want to have 2 tablets a day, because you have to take 2 tablets of Pirtobrutinib, and we know it will work. Few side effects. That's a good opportunity for Pirtobrutinib once it's approved in frontline. And the other group, high-risk patients. So we know there are still patients that have a problem with the time-limited therapy. So TP53 aberrant patients and patients with a highly complex karyotype. So these are also subgroups I would offer Pirtobrutinib once it's approved in frontline.
So can you go into more details about the time-limited use of modern therapies?
Yes. So there are actually 2 main groups of time-limited therapy. So besides chemoimmunotherapy, we have discarded more or less. This is venetoclax obinutuzumab, so BCL2 inhibitor plus a very strong anti-CD20. And the other one is the BTK inhibitor plus venetoclax. So what's in the market? Ibrutinib plus venetoclax or acalabrutinib plus venetoclax. So we have shown in the CL17 trial that ibrutinib plus venetoclax is as good as continuous ibrutinib, at least when we look at this for 3 years. So that's the observation time. The same is true for venetoclax obinutuzumab. It is as good as ibrutinib continuously. And you can guess, what will the patient choose? They want to have time-limited therapy. So it's quite easy that I plus V or Ven plus OB is, for the majority of patients, good enough.
Yeah, and these regime is obviously also here in Norway we use it quite a lot. Is in the first line treatment as well as in Germany, I guess. Yeah. So can you just walk us through before we go into a more deeper discussion about the the clinical importance of the BRUIN studies. Can you just first walk us through the BRUIN CLL 313, where pirtobrutinib was tested versus chemoimmunotherapy, which is probably quite an old regime at the moment. But still, walk us through it.
Yeah, it's totally correct. That's a little bit old-fashioned, I would call it, because who is using bendamustine rituximab nowadays in frontline? But I mean, we have to be fair. The authorities asked for this kind of comparison, and it's clear it's a positive trial. So what has been done? Almost 300 patients were randomized between pirtobrutinib and bendamustine rituximab in the frontline setting, and so we had positive results in all subgroups. One very important point is that progression-free survival was the primary endpoint, and so we have to look at this. We can say that the 24 months PFS rate for pirtobrutinib was in the range of 93%, so to be exact, 93.4%, and bendamustine rituximab was only 70.7%, so the hazard ratio is 0.2. This means we have an 80% risk reduction in progression-free survival. I mean, this is very good data set, and this is true for, as told, for almost every subgroup, including also unmutated cases with complex karyotypes, with TP53 mutation, et cetera, et cetera. With respect to overall survival, we always see a difference between Pirto and Benda. I mean, this is a secondary endpoint, but the hazard ratio is here 0.26. So in both endpoints, clinically meaningful endpoints, we have a positive trial, and this, I mean, we can guess will lead to an approval, because I mean the difference are very huge, you know, and I mean in a similar way other drugs have been approved. It shouldn't be punished for pirtobrutinib. I mean, this sometimes takes a long time until it's approved. I mean, this has and the main thing was the side effects were quite good. So we had only very few infections. We have only few cardiac arrhythmias. So things we are afraid when using a classic BTK inhibitor like ibrutinib. I mean, the toxicity profile, put it this way, is much better for pirtobrutinib in this case.
Very interesting. Shall we just move over to BRUIN CLL 314, which pirtobrutinib were tested via the old, let's say that drug ibrutinib, and it shows superiority for a non-covalent BTK inhibitor versus ibrutinib. What stood out for you in this study, Professor?
Yeah, I mean, this is exactly the head-to-head comparison. So between pirtobrutinib and ibrutinib. This is the first trial. We have a comparison of a non-covalent BTK inhibitor versus a covalent BTK inhibitor. I mean, this is novel. And so everybody wants to have a comparison. I mean, nowadays we would say, let's test it against acalabrutinib or zanubrutinib. But I mean, a trial has been done some years ago. And so what can we take from this trial? It has been tested in the frontline setting and in the relapse setting. In both scenarios, I mean, in this case was overall response rate, the primary endpoint. So both groups had a better outcome with pirtobrutinib. So again, a positive trial. And the toxicity profile, again, was much better with pirtobrutinib versus ibrutinib. So another proof we have seen with different trials in the past, Sanu versus ibrutinib, Acala versus ibrutinib, but these two trials have been done only in the relapse setting. So this is the new thing. First trial, also in the frontline setting, head-to-head against ibrutinib. I mean, this also answers a lot of questions. I mean, we would have guessed if Acala is better in the relapse setting, should also be better in the frontline setting. But now with Pirto, we have the evidence. Pirto has been tested in the relapse setting, has also been studied in frontline setting. This is good. The only question you might ask this as the next question is, what would we do once we have a relapse on Pirtobrutinib? So this is a little bit black box. Usually I like to have a drug as a backup, and Pirtobrutinib is super, it's a super backup drug because I know at this point I can use it after a covalent BTK inhibitor, Pirto works. But I don't know for sure, will a classic BTK inhibitor like acalabrutinib work after Pirto? What should we do after Pirto relapse? That's a little bit the thing. I mean, science has to go on. I mean, it will be answered, this question, but it will take another year.
You just took my question. So should you actually use the best BTK first or later? That's a really difficult question, which probably is not a clear answer to at the moment.
Absolutely correct. I would say when you have an 80-year-old patient, the normal life expectancy, regardless of the CLL, will be limited. From a statistical point of view, we know 8-9 years. Once you are 80, you have 8-9 years to live. And for this period of time, you don't have to think about sequencing. So Pirto might be the perfect drug because we know low side effects, it's working. That's a good option. But I would see it in a different way for a 40 or 50-year-old CLL patient. Then I would wait for more scientific evidence what to do in a relapse.
Exactly. So let's also talk a little bit about the issue that you started with, the CLL17 study, for instance, how we extrapolate this data to kind of modern regimes to compare it with more modern regimes. So to what extent can we extrapolate these data to modern fixed duration regimes like venetoclax, obesitumab? What are your take on that one?
We have to say that the Pirto is maybe even easier to use than venetoclax obinutuzumab. This has to be stressed. It's 2 pills a day, so 1 drug a day. With ibrutinib plus venetoclax or acalabrutinib, you have to take care of neutropenias in the patient, etc., etc. So it's a little bit more. You have to do more work for the patient. And infection-wise, this also has been seen in CLL17. Venetoclax OB has caused 22 deaths. That's a lot. And in this, we had 303 patients in this cohort. In 22, you can guess it's almost close to 7-8%. So Ven-Obi obviously can cause a lot of infections due to this very strong anti-CD20. This problem you don't have with Pirto. The infection rate per se, if you do a cross-trial comparison, it's not scientifically totally correct. But you get the idea. It's maybe better tolerable than venetoclax-based therapies, especially Ven-Obi.
So you have a kind of a dilemma how to use in your opinion, the most potent drug combination with venetoclax. So you're saying that combination should probably be reserved for younger patients?
So I would say venetoclax obinutuzumab is a good choice for younger patients and patients that do not have a long history of infections. On the other hand, I plus V, so ibrutinib, venetoclax, just to discuss outside of Pirtobrutinib, ibrutinib plus venetoclax is also a good option for younger fit patients. I can stop the treatment after 15 cycles. This means roughly 14 months of treatment only. And the question you also might have in mind is, what about acala plus venetoclax? Because this is also approved in Europe. It's not it's also approved in the US. So we have a little bit the agony of choice in Europe, even more than the US colleagues, because we have I plus V and A plus V, acala plus V. Acala plus V is a very interesting drug combo, I would say, for elderly patients that want to have a time-limited therapy, because we know acalabrutinib does cause less cardiac side effects compared to ibrutinib. So this is a little bit the choice I would make in the frontline setting.
So you talked about acalabrutinib and venetoclax. Do you have any more to add on that one?
You mean acalabrutinib plus venetoclax?
Yeah, exactly. Yeah.
I mean, this is for me a very interesting combo for elderly patients that want to have a time-limited therapy. So acala we know is only 0.3% cardiac arrhythmia, so it's a very safe drug. Venetoclax, we have to take care of neutropenia, but otherwise you can give this also to a 75-year-old. With ibrutinib plus venetoclax, you have to be careful, because we know that we put patients at risk with ibrutinib. That's more a time-limited therapy option for younger patients. So this is the dissection I usually do in my everyday clinic.
Exactly. So what's the final take-home message to physicians after these two studies, CLL 313 and 14? What's your main recommendation at the moment?
There is the perspective of a very tolerable, efficacious drug that might be easily used in elderly patients that need continuous therapy, regardless of their molecular profile. And it might be easily used for younger patients, plus elderly patients, with high-risk features like TP53 and complex karyotype. So these are the two groups that might benefit from Pirtobrutinib frontline once we get the approval and label for Pirto frontline.
Exactly, because today Pirtobrutinib is only in second-line treatment in USA and Europe as well, of course. Yeah,
absolutely correct.
The treatment landscape of CLL is rapidly changing, which I think you have put very, very clearly for our listeners. You talked extensively about CLL 17 study, but you also have a new study, CLL 18, which I think is very, very interesting to talk about. So could you give us a perspective of that study as well?
Yes. I mean, CLL 18 is the new frontline trial that's coordinated by the German CLL study group, but we have participants all over Europe, including the Scandinavian countries. And so the question is, which is the best frontline therapy? Is it Ven/Obi? And we're only talking about time-limited therapies in this case, so also very interesting. Or is it a combo of Pirtobrutinib, so the new non-covalent BTK inhibitor plus venetoclax, because we don't want to use Pirtobrutinib continuously for all patients, but also time-limited. And I think the juicy, fancy thing is also the third arm. This is venetoclax standard plus Pirtobrutinib up to 3 years, but the length of the therapy is MID guided. So we measure the minimal residual disease once a patient is confirmed at least twice to be MID negative, treatment is stopped. But this, I think, fills a little bit the gap that with time-limited therapies like ibrutinib plus venetoclax, acala plus venetoclax, we only have, out of the moon defined, okay, there's 14 cycles, 15 cycles, but it's not adapted to the individual patient. Now with Pirto plus venetoclax, with MID guidance, we have an individualized treatment length, but still time limited. It's not 1 year, it's up to 3 years. I think this is the novelty of this trial, and so I'm also proud that Scandinavian countries are taking part in this trial.
So when can we expect the first readout of this study?
I mean, the trial started recruitment in this summer. So we have the first patients in. And if we extrapolate from CLL 17, usually our trials are running quite fast. I would say in 2 years, we might finish recruitment and just give us a few months to look at the data I would say in 3 years, we might have the first readout. This is an educated guess.
Yeah, so at AHA or ASH in a couple of years, we will be looking forward to have the new data. That will be groundbreaking, I think.
I hope so.
Yeah. Professor Wendtner, thank you for helping us to put BRUIN CLL and the treatment landscape in a very, very interesting perspective for Scandinavian physicians. Thank you very much for your time.
Most welcome. Most welcome.
Thank you.